Good evening to the April Fool's edition of the Ask Me Anything. So, had some great questions. I saw a lot of lipid ones, a few arrhythmia ones. So we'll hit them in just due order. But hope you guys are having a great week so far. I was just down in Tampa visiting some family, soaking up some sun. And next weekend I'll actually be going to Atlanta to the American College of Cardiology conference and learning a lot of things about AI. I'll also go through the expo hall and find out if they have any new cool toys or anything that I can use to help better screen cardiovascular risk factors for my patients at Apollo Cardiology. So I'll probably be putting a few stories up in my post starting on Saturday next week when I'm at the conference in Atlanta. So why don't we get started here tonight? So first question up is about red and infrared light. The person is reporting that some of the quantum biology advocates suggest that red and infrared therapy after sunset is not best. What are my thoughts? It depends on how sensitive you are to the intensity of the light, and does it affect your sleep quality? That's the biggest concern. So if you can sleep well, and potentially if you're tracking your sleep with an Oura, Whoop, BioStrap, Withings, whatever you like to use, and your sleep metrics are good and you feel like you have the brain power you want the next day, then not as big of a concern. But some people it's a little bit stimulating too and affects their sleep quality. That being said, the red light therapy panels tend to recommend during daylight hours. The infrared, it depends if you're using a panel, probably wouldn't use it too close to bed. But if you're doing like a sauna type of therapy with infrared, often that's very relaxing. Generally maybe do it about an hour before bed, and as you're cooling off, the sleep quality tends to improve. So that's usually how I kind of think of that one. So, question about visceral fat. What is the best plan to lower it? Optimize your skeletal muscle. Your skeletal muscle is what generally helps with everything in your metabolism. So focus on resistance training, a few days a week. Work with a trainer if you don't know how to do the resistance training that you need to do without injuring yourself. High quality protein, mainly maximizing the amino acid leucine to trigger muscle synthesis. So at least 90 grams of protein a day, but generally a gram per pound of your ideal body weight. If lifestyle alone doesn't do it, then medications like metformin may have a benefit. The person also had on that they have a calcium score over 200 and already on 20 milligrams of a statin. So work more on the metabolic markers. The statin's really not going to have too much effect on the visceral fat. Question about, do I see any significant improvements in omega-3 to omega-6 ratios with diet alone? At times, but generally you're probably be eating seafood 4 to 5 times a week and really watching that you're not getting a lot of vegetable oil in foods, especially when you're eating out. But sometimes see it. Optimally like to see the ratio close to 4 to 1, so no more than 4 times the amount of omega-6 to omega-3. And if you're doing the Boston Heart, it's actually the inverse. They have the 3s divided by the 6. So generally I like to see the ratio greater than 0.25 on the Boston Heart Lab panels. All right. Oops. Next question up tonight. What causes Lp(a) and ApoB levels to increase? Their Lp(a) level is 746 and their ApoB is 110. So that would be a significant discrepancy between those two, because Lp(a) will always have an ApoB protein on the outside of it. So you have to see if there's like a decimal point missing in that Lp(a), or is it measuring the nanomoles per liter versus the milligram per deciliter version. But many things tend to increase ApoB. You're a hyperproducer of sterols, hyperabsorber of sterols. Are you becoming insulin resistant? Are you postmenopausal if you're a woman? There's many things that affect ApoB, but many of them are genetic. There's nearly 3,000 genes that affect ApoB. Lp(a) is also genetic. It's on the 6th chromosome, but Lp(a) rarely changes significantly, maybe 15-20% either way up or down, because it's under such genetic control. But one thing I learned recently is that if you have elevated levels of interleukin-6 or IL-6, that will upregulate the production of more apolipoprotein A proteins in the liver, and you'll attach that apolipoprotein A protein to an LDL particle, and you'll make more LPA from it. So it may be inflammation driving both of those in parts. There's any tips related for vertigo, any connection with heart issues? None that I'm directly aware of. I mean, vertigo is generally either an inner ear issue or it can be due to cerebellar issues. If it's cerebellar, then potentially heart issues if it's due to atherosclerosis. But most of the time it's an inner ear problem. So generally want to work with a otolaryngologist or a neurologist who's well versed in vertigo treatment. But sometimes it's certain maneuvers like the Dix-Hallpike maneuver can sometimes help with that. But not my area of expertise anymore. This question about trimethylene glycine for blood pressure. I've not seen it used for that. I've mostly seen it used for elevated homocysteine levels, which if you lower homocysteine, sometimes that will help lower blood pressure. So that maybe the backdoor pathway and how that would help, but generally well tolerated. I don't see a lot of side effects from it. Question about a 64-year-old woman, 17 years post-menopause, occasional to frequent PVCs, no discernible reasons. So premature ventricular contractions are common. Sometimes they're hormonal induced. So drop in estrogen, you maybe see them more. The previous question about the omega-3 to omega-6 ratio. If you're low in omega-3s, often we'll have more premature ventricular contractions. If potassium or magnesium levels are low, more premature contractions. But often it's nonspecific. It's high oxidative stress or high inflammation. And you got to try to figure out what might be driving the high oxidative stress or inflammation. The other thing that sometimes will drive it is non-native EMFs. So cell phones, Wi-Fi, Bluetooth. Some people are more electrosensitive than others. So you have to kind of take a log of when do you notice these PVCs happening more and see if you can pin it down to a certain location. But the workup, is not too challenging to undergo. It's wearing a monitor to figure out how many PVCs in a 24-hour period, potentially an echocardiogram to see do you have a normal left ventricular size and function, and then biomarkers, blood work essentially to help figure it out. Most of the time they're benign though. Sticking with the arrhythmias, so somebody's asking about premature atrial contractions that are symptomatic and resistant to all pharmacological therapy. Well, I'd have to know what pharmacotherapies were tried. Was it actually including antiarrhythmic medications, or is it just beta blockers or calcium channel blockers? But similar to premature ventricular contractions, this person's sensitive to EMFs. Do they have electrolyte imbalances? If there's thyroid overactive, do they have high oxidative stress, high inflammation? There's always some trigger that's firing them off, and trying to figure out, is it an environmental situation? So if it's always at home, it's always in the bedroom, it's always at work, it's when the person's under stress, when they drink more caffeine than normal, when they drink alcohol, there's always some trigger. You just have to do some detective work to try to figure out what's driving it. This is a very good question. I don't think I've answered this one in quite a while. So what is the difference between VLDL and LDL? Is one worse than the other? So answer the second part, no, they're not necessarily one's worse than the other, but people tend to have a lot more LDLs. Both VLDL and LDL are particles, and on the outside of those particles is an apolipoprotein B apolipoprotein. So ApoB is the number that you want to look at, and 90% of them are going to be LDLs. But VLDLs in some individuals will be very high. Often the person will be insulin resistant or pre-diabetic or diabetic, and they'll have often very high triglyceride levels. VLDLs are like beach balls full of triglycerides. And when they drop off the triglycerides to the periphery, they basically shrink down from a very low density lipoprotein. They become an intermediate density lipoprotein, which is like a halfway step, and then they keep losing more and more triglycerides, and they eventually become an LDL particle. So they're kind of cousins in many instances, but both can be atherogenic. But if you have high VLDLs, often it's a marker of insulin resistance. There are some individuals with genetic abnormalities why they'll have high VLDLs, and so you can do GB insight panels to figure that part out. Question about high LPLA and ApoB, but inflammatory markers are healthy, as is insulin and A1C. Thoughts on cardiovascular risk? Good question. But this is only one part of the equation. So often when I sit down with patients to review their testing, we'll tell them we're going to go through the biophysical, and then we'll also go through the biochemical. You just gave me the biochemical. So what is floating through the blood, or what did you inherit from mom or dad? Important, but we really want to know what is going on with the arteries. Do you have stiff arteries? Do you have an abnormal pulse wave velocity test? Do you have high central aortic blood pressures? Do you have abnormal endothelial function, such as an endopat scan with the result less than 1.68 on the reactive hyperemia index? Do you have a carotid intimal medial thickness testing scan with a vascular age that's higher than your biological age? Or do you have plaque in your carotid arteries? Do you have an abnormal calcium score test, or an abnormal clearly CT coronary angiogram? If that's true, then it doesn't matter so much that your inflammation markers are normal now. You have plaque in your arteries. Inflammation would have been present in the past, and good job, lowering it now. But you have to look at other things. As I said earlier, there may be up to 400 markers that can damage your arteries. Those are just 3 or 4 of the ones that you listed. Those are important ones, but you still need to know, are the arteries getting impacted by those? Then that determines the intensity of trying to lower ApoB. And if inflammation and oxidative stress are truly normal, great. The other levers you have to look at is the ones that affect nitric oxide. So do you have normal uric acid, normal homocysteine, normal asymmetric dimethylarginine, normal urine microalbumin creatinine? If so, good. You probably have better levels of nitric oxide. If you have nitric oxide that's optimal, then ApoB and LPA may be less atherogenic in those individuals, potentially. Question about a particular supplement called GG Pure. I've not heard of it, so unfortunately I cannot speak of it. But if you have a website link about it or an article, just send me a message about it and I'll try to take a look at it. And we talk about it on a future AMA. So don't have full context on this, but somebody says, do I think 58 is a high score for plaque? So I'll take some liberties and kind of suggest that, like, if 58 is a calcium score test, then it's not high risk, but it's still abnormal. The calcium score test should always be 0. I've seen patients in their 80s with scores of 0. But it's common that people will develop plaque in their arteries in their 50s, 60s, and 70s. And that is demonstrated by an abnormal calcium score. The higher the calcium score, the more plaque in the arteries. And it depends on age. A score of 58 in an 80-year-old, probably par for the course and not so concerning. Score of 58 in a 40-year-old, really concerning. So, I would still want to do the biophysical testing. So looking at carotid intimal medial thickness, is this plaque old plaque or new plaque? Are your arteries elastic? Do you have good endothelial function? That will tell you what's the propensity to continue to lay down more plaque. And then you can do the advanced labs to figure out genetics, inflammatory markers, oxidative stress markers, endothelial health markers. That will determine, is this truly a high score that's going to stay stable or a high score that's going to continue to go up. And then this one, I'm probably going to need the person who submitted this question to point me to the article they want me to review for this. But somebody's asking, what do I make of the higher mortality rate in the treated versus the placebo group in the 4-year trial? So in the actual trial, this was not shown, but I recently had a patient kind of bring this part to my attention as well. And it was a post hoc analysis where they redefined how mortality was calculated, and maybe the numbers did look a little bit different. But I haven't had time to yet to fully dig into that article as well. But the 4-year trial was looking at one of the PCSK9 inhibitors. I believe this one was the Repatha trial. The other one's the Odyssey trial, which is Praluent. I always get the two mixed up, which one was which. But the PCSK9 trials were overwhelmingly positive in a short period of time, where significant reductions in ApoB had less MACE, major adverse cardiovascular events, in a very short period of time. Vascular disease is a lifetime disease. It's not something that you usually are going to stop in 1 or 2 years. And these trials showed very significant improvements in less than 3 years. So I have not yet seen convincing data that the formulary trial was harmful. So if you have an article you want me to review, then just send me the link in the DM and I'll take a look at it for you guys. But if the question was asking, do I still use PCSK9 inhibitors? Absolutely. I use them routinely for patients who can't tolerate statins or have high-risk vascular scans that aren't getting a goal with their other treatments. So I've answered this question before, but I'll answer it here again. So somebody's asking about my opinion on Cavidex. Is it worth the hype of cleaning your arteries of plaque? And if it does, how long somebody will take? Any side effects? So I don't have significant experience with my patients. I have a couple patients who've decided to go down the route of using Cavidex or cyclodextrin. Dr. James Roberts in Ohio has a larger case study. So if you're really interested in the potential benefits, I would look up his website, heartfixer.com, and look for Cavidex on that website. Usually the treatment protocol is 2 months on, and then repeat some type of vascular testing within a year and see if the arteries are stable. If not, then do more rounds of Cavidex. So far, I have not seen any significant reports of any particular side effects with Cavidex. And the cost is generally about $200, $250 a month to do it. That's probably one of the biggest sticking points with it, is just the cost of it and the lack of clinical trials and knowing how long to use the supplement for. Are omega ratios based solely on diet and supplementation, or will anything else improve them? Mitigating artificial light at night or even during the day. Excessive blue light through your eyes is going to decrease your DHA levels in your eye, and you're going to have to keep repleting more and more of it. So controlling your artificial light exposure may improve them. All right. Which company do I use for ordering these advanced labs? The majority of them are either Boston Heart Diagnostics or Cleveland Heart Lab, which is a subsidiary of Quest Labs. They tend to have more of the advanced vascular inflammatory markers and oxidative stress markers. But even basic LabCorp, Vibrant America, they can do ApoB and particle count. It's just they don't have the full complementary of advanced vascular testing. And since I'm the heart attack prevention cardiologist, I'm using the tip of the spear labs all the time with my patients. What is better, a CT angiography or a heart MRI? Those are apples and oranges types of technology, and so it depends on what question you're trying to answer with the test. So the CT angiography is going to tell you more about plaque characteristics and stenosis. There are some reasons to do CT angiography to look at valve, but not many people would use it for that. And then heart MRI is mostly if somebody is concerned about a cardiomyopathy or myocarditis. So apples and oranges technology depends on what you're wanting to look for. Great question about calcium scores. How frequently should somebody do them? Let's just start with, the guidelines are a little bit different than maybe the way that I would recommend it. But first off, this is for people who have not previously had cardiovascular events. So if you already had a heart attack, stroke, stents, bypass, you do not ever need a calcium score test again. This is for people who have never had an event and generally are considered low or intermediate risk. So I used to say 40 would be a cutoff, but I've seen some people under 40 recently with very high calcium scores. So generally, somewhere 35 would probably be a starting point for somebody to consider. not everybody's a good candidate. If you're a woman with no other significant risk factors, maybe you wouldn't do this test until you're 40, 45, but 35 can be a starting point for some people. If your score is 0, probably every 3 to 5 years you would repeat the scan. The reason you don't do it every year is that, it's radiation. Not a lot, but you still want to minimize the medical radiation you're exposed to through the 80, 90, or hopefully 100 years you have on this earth. If your score is above 0, for the most part, you're done. You never need another scan again using this type of technology. You should probably consider a CT angiogram at that point to figure out how much soft plaque you have. So, calcium score test, start about age 35. If your score is 0, likely repeat it within 3 years. If your score is above 0, very often never repeat it. So I'll give a generalization on this. I can't tell you exactly what to do because you're asking, should you stop a medication? I can't stop medications for patients that are not mine. But in generalities, this person reports that their ApoB reduced from 190, which would be sky high, that'd be 99th percentile. So 99% of people would have values lower than this. It dropped from 190 to 33 on Repatha, which is a PCSK9 inhibitor, Zetia, which is a cholesterol reabsorption inhibitor, and Livalo, which is the newest statin. So triple therapy to get the ApoB down to 33, which is under the 5th percentile, which is an amazing drop. So Livalo, the statin, bothered this person and they stopped it. They're reporting that their provider wants them to potentially stop the ezetimibe in 90 days as well and then retest. So I wouldn't know without more information, but typically, I would do a Boston Heart panel on this person to figure out, are they a hyperproducer of sterols? Are they still a hyperabsorber of sterols? And that would give you an idea, which treatment is working best. But the goal is to keep it down significantly if you have significant plaque in the artery. So, most people should generally shoot for an ApoB of 70 or less. If they're higher risk, ApoB under 55. But the reason that I wouldn't know for sure to stop something is you want to be looking for the cholesterol balance test on the Boston Heart panel. If your desmosterol levels are suppressed, then maybe it's reasonable to back off on some of the medication, but not all of them. There's a patient asking, do I do virtual consultations? Basically, the answer is yes, but the initial visit is always in St. Louis at my practice at Apollo Cardiology. The reason being is that allows you to get all the vascular testing in our office at the same time. All these advanced blood testing that we're talking about, we have the ability to draw these labs in our office at that time. Also available to do physical exams to assess, do you have a heart murmur, a carotid bruit? Is there other testing that would make sense for you? So all initial visits at our practice are done in our office, and then the follow-up visits can be done virtually. All right. So I think I got through all the questions tonight. There's some good ones. Really appreciate the ones about VLDL and LDL. There's some LPA little questions. There's a couple questions about nitric oxide. So favorite topics. So next week I'll actually be traveling in Atlanta. So I don't know exactly what time I'll jump on here and do AMA. I might do it early in the day, or maybe I'll actually move it up a little bit. But I'll be at the American College of Cardiology Conference starting on Saturday. It's an enormous conference. I'll probably be sticking to more of the preventive cardiology topics. I go see a couple different ones about artificial intelligence and heart health. And then also going to cruise the expo hall and look for, if there's any new toys or testing gear that can help me look at people's arteries and figure out, how old their arteries are at an earlier stage than what I'm currently already doing. So I'll probably do some quick lives when I'm walking through the expo hall, if that's allowed, show you what's going on down there. And then if it doesn't work exactly at 6 p.m. next week, Central Time, I'll give you what time it's going to work for you guys. So hope you guys have a great week, and we'll see you next time.